Welcome to the Wild Physio Podcast with your host, Andrew Wild. Today, I am super excited. I have Dr. Justin Rowe and Tim Musgrove on, who are both orthopaedic surgeons specialising in ACL reconstructive surgery. How are you both?
Thanks, Andrew. Thanks for the invitation.
It's good to be here.
So, Justin, you're backing up. We obviously had you on the Hybrid Therapist podcast. That would have been probably about nearly 2 years ago, I think. So welcome back.
Pre-COVID.
Pre-COVID, exactly. It's a weird world we're living in. Thanks for coming on, Tim. Really appreciate the time.
But I'll take my lead from my experienced colleague.
Yeah. Have you been on a podcast before, Tim?
No, so it's all new. Let's go.
All right, let's do it. So I'm going to hit you two with these yes, no, maybe questions to start with. So all I want is just an answer, and then we're going to dive into why after. I'll ask the question. We'll go with Justin first, then we'll go for Tim after that. First question, do too many people have ACL reconstructive surgery for an ACL rupture? Justin?
Yes.
Tim?
I'll second that.
Cool. Does a ruptured ACL have the ability to heal without surgery? Justin?
The definition of healing has to be discussed, but yes.
Tim?
The answer is yes, and we can define healing after.
Perfect. Yeah. Are women more prone to ACL ruptures? This is a pretty easy one for you to both answer. Justin?
Together, yes.
Yes.
Do artificial playing surfaces increase the likelihood of an ACL rupture?
Justin? Yes, but we can elaborate.
Tim?
I think it's a maybe from me.
Okay. Do bladed studs on boots increase the likelihood of an ACL rupturing compared to rounded studs? Justin?
Well, I'll go maybe because it's depending on the grass or the surface it's standing on. So maybe.
Tim?
A maybe. Fence sitter.
Yep. Can an MRI definitively tell if an ACL is ruptured or not? Justin?
Definition of rupture has to be discussed, and no.
Tim?
Same response. Definition of rupture it hinges upon.
Yep. Do rehab clinicians load ACL reconstructive patients too early in rehab?
Maybe. Maybe.
Tim?
Maybe, but hard to track in a practical orthopaedic practice.
Yep.
Yeah.
Are clients discharged too soon post-op ACL reconstructive surgery? Justin?
Discharged from rehab, you mean?
Yes.
Yes.
Tim?
I think it's a maybe because the loss to follow-up's greater than 50%, if you're honest.
Yep. Last one. Should you wait a minimum of 9 months before you return to sport post-op ACL reconstructive surgery?
Yes, but we can discuss that. But generally, yes. If I was asked that straight up, yes.
Tim?
Mine's a firm yes.
Firm yes. All right.
That's probably my firmest yes today.
That was very firm. Off the fence.
Yeah.
All right, let's get into the first one. Surgery versus no surgery. Now, Justin, you've talked about this before on the previous podcast about copers. Let's dive into it. And also, I wanted to dive into a lot of the research behind the surgery versus no surgery and also the healing rates. I've chatted to Tom Cross and he was going to potentially come on this. He's obviously doing some great stuff at the Stadium Clinic at the moment. What are your thoughts on the surgical versus non-surgical route for a client that has torn their ACL?
Yeah, I think it's all about their expectations, patient's expectations, and the patient's clinical laxity. I think it does not matter what the ACL, like what the MRI scan looks like. I think, and that's important, who the patient is in their environment and what they want to do, and what does their knee feel like? How loose is it? There's some loose knees that don't need to do much but walk down the street, and there's some not so loose knees and they want to compete at a very high level in certain sports that we know are high risk sports. So that patient would require a stabilisation procedure versus the other patient not. So that would be my general discussion and advice to patients is that depends who you are and how you feel, and how I feel you, so to speak. Good clinical examination, and that's only comes with experience, I think.
Yeah, and you've previously mentioned that it needs to be an objectively stable knee. There's no giving way. The HOP tests are above 80%, and there's a couple other things in the literature that are mentioned, such as the self-reporting global knee function rating and the COS ADLS. Tim, you've got anything to add?
Yeah, I guess if I'm seeing a patient, I'll take it from that perspective. I reconstruct for functional instability. And what I mean by that, that could be a sport choice, a work choice, an activity of daily living choice, or leisure pursuits. So if they demonstrate functional instability in their knee and have the appropriate signs, objective signs, well, then I think it's appropriate to consider elective reconstruction. But it's an elective choice. I say it's not selective on the injury. So I do put it to them that you can live without an ACL. You can be fit and healthy without an ACL. But if you have functional instability and there's an impairment to your function, discuss the reconstruction. Yeah.
Now, in regards to the ACL's ability to heal, what's your view on it, Justin? Obviously, Tom Cross is doing some really great work at the stadium with a non-operative bracing protocol. What are your thoughts on the bracing protocol? And also, what are your thoughts on whether the ACL heals or not?
Well, we've known, Andrew, the ACL heals for many, many, many years. This is not a new thing. Mm-hmm. And it's like the anterolateral ligament that everyone thought, was a new thing, new discovery, 4 or 5 years ago when it got put in the New York Times. It's not a new discovery. The anterolateral ligament had been discovered many years ago, and the fact that some knees stabilize after ACL injury has been known for many years. And Sophie Armstrong and myself and Leo Paczewski reported on a whole group of healed ACLs back in 2009-10, where out of 1,500 ACL injuries, we had 21 that healed. And we followed them with an acute MRI scan, clinical examination, and then MRI scan at 12 months, and we followed them for 5 years. So we documented a group of patients that healed and got return to sport with high level of function. And we also documented re-injuries. We had 2 re-injuries in 5 years of those 21 patients. So it's not a new thing. And my concern about this new discussion on it is that the potential damage of the new treatment that's being instituted, which is the brace. We found all our patients healed without being braced at 90 degrees. Some of them were in a brace to protect their MCL with those grade 1 to 2 MCLs that we see so often. But the brace did not have any influence on the healing as far as we could tell. And you can't really tell in 20 patients or 40 patients or 80 patients. You've got to have a lot more patients numbers to differentiate whether it's the brace or whether it's just the biology. So that's my feeling about the healing. They do heal, and we know that. But I think we've got to move on about what makes them heal. We've got to be able to identify who is going to heal. And I use that again with clinical experience. A patient that comes in that's really stiff after a non-contact mechanism of injury on the soccer field or the netball court versus a patient who comes in who is not stiff and they look as though they've, haven't had an injury at all. That patient who's thrown out a whole lot of healing factors and is a reaction to that injury, that trauma, in my hands is probably more likely to heal. So I sit tight on them and I let them rehab and give them time and then reevaluate them. Tim, what do you think?
My expression, you've heard, Justin, for this is that it is not new, it's just news that the ACL heals. So often these discoveries are reported as news, as Justin alluded to, but certainly I did, and I think Justin did, practice before MRIs existed. So before MRIs existed, we were probably seeing this entity of so-called healing of the ACL, maybe not recognizing it, but certainly we were making a judgment on the clinical examination. Was there healing of sufficient structural integrity that the patient wasn't functionally unstable? So I'd come back to my elective choice to indicate operation. Whatever the scan looks like, to an extent, it'll heal. It'll heal to the PCL, it'll heal to the anterior wall. It might heal in what we recognize as a well-orientated continuous ligament, but it still hinges on the fact whether they're functionally stable with whatever healing taken place, because all tissues heal. Any busted tissue will heal. That's nature's intention. But we've got to make sure that that healing equates to the stability, the functional stability. So yeah, I agree. And I think you've got to watch for these patients, but they're not new to us, but it does require review. It does require follow-up consultation, and it does require a bit of more management than just reconstruction.
Justin.
And I think, Andrew, for listeners, for people listening out there, I think you know, he's talking to two orthopaedic surgeons here, but the orthopaedic surgeons these days, we are akin to this management of the patient rather than just operating on everything. So I wish we could get rid of a little bit of the myth out there that if you send a patient to a surgeon, they're going to operate on them no matter what. And I think potentially that has probably driven a little bit of the behaviour of patients saying, oh, you know, I don't want to go and see the surgeon, he'll operate on me. So, but I think Tim can say that as well. You know, we're a lot more conscious these days of the well-rounded patient and the well-rounded decisions, a shared decision-making process that goes on. And I don't think, and I hope that respected surgeons these days are respected more for their management of patients non-operatively as opposed to operatively.
Yeah, I agree. And really, really well answered from both of you. And I've even had so many clients and friends even say, oh, I can't believe it, the ACL can heal. But if you look at the research, and as you have both said, we've known this for a very long time. You know, there's a paper from 1994, Ihara, that mentions that it can heal. So we've obviously known for a very, very long time. Now, in regards to
the difficulty, just to butt in, Andrew, the difficulty with even the perfectly healed ones that we can say have the right orientation and the right signal on an MRI scan and the right MRI scan, I still can't attest to the durability and the longevity of that. But I think you're still better to have that than to have a failed reconstruction. So are you better to have had a healed anterior cruciate that provides you functional stability, and then you go and re-injure that, or were you better to re-injure a graft? I'd say I'd like the former rather than the latter.
In regards to spontaneous versus bracing in terms of the conservative management to try and allow the ACL to heal, what's your take on bracing versus spontaneous? Because I found two research studies by Costa Paz and also Kurosaka that have both indicated that the ACL spontaneously heals, as you've mentioned, Justin, without bracing. What's your take on brace versus no brace?
Tim?
I'll go. Okay, I'm happy to go. I talk about nature's brace, right? So when they come in injured, you'll see a variety of presentations. And the ones to me that seem to show some potential for healing might be those with a painful endpoint and a lot of spasm. And so that to me is nature's brace. So I watch those patients and brace them in the position that they present. And then I'll watch them each 2 weeks, re-examine them, and I may adjust an external brace to the degrees of active range they have. Now, I do want to say something just in support, I suppose, of the research that Dr. Tom Cross is doing. It's done in a research manner. There is some interesting work on the MRI to see where the ACL ends up in that 90-degree position, right? So I think if we just make sure we have it in that research arm, it's still a very interesting project. But I do think there are other positions where the scaffold, the bridging, the apposition might be sufficient if we just respect nature's brace. But there's no substitute, I guess, in any of those protocols for examine, re-examine, and reconsider if it's not showing signs of functional integrity.
Justin?
Yeah, I think I agree, as I was sort of saying, how they present into your rooms, how they present on the field, and then the day after and the day after that is so variable, and it's biological, and it's a reaction to the injury. So yeah, I think that's the thing that traditionally we've said, oh, you're going to have surgery, so you've got to prehabilitate, you've got to do this, that, and the other thing. But I think there's more, we're learning more now from these healing or stabilizing knees, that maybe, yeah, just give it some time. In modern day, however, patients, if they want an operation, they want it yesterday. So we are in a balance. I don't know what, we don't know what the right answer is. There's lots of variables. So I think it's a watch this space, but as Tim says, it's everyone knowing, whether you're a physio on the field, whether you're a sports physician, whether you're a nurse in the health centre at the school, whether you're an orthopaedic surgeon, we all should be aware of, you know, the biological response to injury, and respect that to a point with the various ways we are able to treat and influence that.
Well answered. In terms of the MRI being able to definitively tell you whether the ACL has been torn, you also both mentioned you need a defined rupture. What are your thoughts on this? Because I know, Justin, you've got a few thoughts, and no doubt you do too. You do as well, Tim. Fire away. We'll go with Tim first.
Yeah, well, I suppose you look at the soft and the hard tissues to simplify it. Okay, we're focused on the soft tissue. Well, so I will look at the orientation, continuity of the ACL. There are patterns of injury. Whether you believe there's 2 bundles or 2 million bundles, that's probably a debate for another day. But certainly any disruption within the ACL, you can tell from MRI scan. Then we look for associated injuries, particularly the bone bruising pattern, and any peripheral injuries to the collateral ligaments. And of course, you might, or sometimes miss, in fact, more so on an MRI than sometimes the X-ray, the Sagon fracture. But you look for those associated injuries, meniscal injuries as well. But I think the MRI, you know, interpretation is reasonably straightforward. I guess the point to drive home from my point of view is I get concerned with the bone bruising pattern. If the bone bruising pattern is there in the typical anterolateral aspect of the femur and the posterolateral aspect of the tibia, I have a high concern that whatever that anterior cruciate looks like, it may not be one that turns out to be functionally stable. That knee has suffered a significant rotation to basically get around the corner for your femur to whack against your tibia. So they're an injury of concern. And I guess you'd have a heightened concern with the collateral injuries as well. But I've been surprised, though, in some of those that may have shown a potential for heal based on those clinical judgments we've talked about. Some have been those ones with that rotatory pattern of bone bruising. So I don't know that it's an all or none thing, but it's just something to be wary of. Justin?
Yeah, I agree. There's grading of injury. Grading of injury there has to be because, you know, the ACL is not a straight up and down structure. So it goes across the knee from anteromedial to posterolateral, and the more rotation you get, the more injured it is. It's not always a front to back translation event, which we know. So there has to be a grading of injury, and the MRI scan is not a rotational 3D imaging modality. So as yet, we cannot image that MRI in 3D, image that ACL using a 3D MRI scan. So we do that in our head. And that comes from experience of seeing the ACL in real life in 3D. And there's not many radiologists who come into the operating theatres anymore. So, and if they were ever in the operating theatre, it was when they were, in their training. So I think the orthopaedic surgeon has to be the most experienced in assessing and knowing and predicting the 3D injury to the ACL with the support of the MRI scan, of course, but not categorically based on the MRI scan report. So that's, again, a caveat for everyone listening. I really am concerned by the reporting of knee MRI by radiologists who, with respect, haven't got the full ability to 3D, examine a knee in 3D like we do. We have the luxury as orthopaedic surgeons. So the comments on MRI reports that hang a bit of a bait out for a patient to, go down a certain pathway or get on a certain train heading to Bathurst, whereas they should be going to Newcastle, is a bit of a concern. So everyone has to be aware of that. It's the MRI scan is not a 3D. So to say it's ruptured or completely torn, or say it's partially torn, has to be taken with a bit of a grain of salt.
How would you like it reported though?
Not at all.
Let's follow up on that. Yeah, there's power in that printed word, I say to my patients. There's a lot of power in the printed word. But then it's all important, as you made the point, Justin, that we have a huge advantage over the radiologist. I always say to my patients, I'm not smarter than a radiologist. I just have a huge advantage to hear the story, to examine the knee, and to look inside the knee. So our correlation between that static supine structural image and what we see in 3D has got to be better. So we're not smarter, we just got a greater advantage. So I think the sequence that if patients are seeing an orthopaedic surgeon, make sure, it sounds a bit trite, but they do take a history, they do examine you, they look at the films themselves before they read the report. Yeah. So if someone's reading a report and deciding to operate on you on the basis of a report, if you cannot run, I would certainly run out the room under those circumstances.
Yeah, no, it's good advice, Tim, isn't it? I remember being. Can you still hear me? Yep. I remember seeing a patient for a second opinion, and he was due for surgery on Tuesday, and this was a Friday before, and I just couldn't believe what the surgeon was going to do. And so then I decided to look at the MRI scan, and the MRI scan looked, as though there was nothing wrong with it. But then I pulled the report out, and the report was for someone else. So, and that's all the surgeon had looked at was the report. And so, I think, again, trying to stand up for the modern day orthopaedic surgeon, as I do, I would hope that well-respected orthopaedic surgeons would be, carry out a history, a clinical examination, look at the investigations themselves, and then make a decision based on that. And it is so common that patients come in and what they've got in their hand is the MRI report, bit of paper. There's the scan, doc. I said, no, the scans are here. They're here on the computer here. I've got them up. I'm looking at them. No, they're here. And are you going to read the report? No. Can I just, read the scans myself? So, it's a common scenario, Andrew, because we're all screen dependent in the power of the written word. But I think it's a good old-fashioned doctor in a lot of us that needs to, or clinician, paramedical, allied health, and medical. Is all we're all got to work together.
There's a lot of new grad physios and also student physios that listen to this podcast, and you've mentioned it before, Justin, on the other podcast. What tests or what special tests you use to diagnose an ACL being torn? What are those tests that you're using? And why do you not use some of the traditional tests that are mentioned in some of the medical textbooks?
Yeah, history, as Tim said, history. listen to the patient, take them back to what happened. And a lot of physios are there on the field. That's great. You can see what's happened. Another, probably Tim taught me this one, but if a patient is sore on the lateral side of their knee following a non-contact mechanism injury, it is not the lateral collateral ligament. If you think it's the lateral collateral ligament, go and find a dark room and have a few thoughts, then come back when that thought goes away and get an MRI scan or examine the ACL, because it's the ACL till proven otherwise. And the simple test I do is Lockman's test. Just put them over your leg on the field, put them over a pillow on the bed. They can't bend their knee up to 90 degrees. It's too sore, it's too swollen. You cannot do an anterior draw. So forget it and just do a simple soft Lockman test. And if it's boggy and if it's swollen and if you go to the other knee and you can feel an end point and you're just not sure on the right knee, on the injured knee, it's an ACL to proven otherwise.
Tim?
Yeah, it's interesting. I like your thoughts too, Justin, because I find in a practical sense in the clinic, the Lockman test is the most sensitive test. I always start with the uninjured knee, obviously, gain some confidence in the patient. And I wait till they are relaxed enough. I put them over my knee as Justin does. And then I say, I just move their tibia forward and they start to feel that end point. They get a proprioceptive feedback that they're feeling something on the uninjured knee. And I say, feel that, feel the stop, feel the thud, feel the end point. Then you walk over to the other side and you've somewhat got their confidence by that time. And then you just move their tibia forward and I watch their face. If they have a quizzical look on their face when you've brought that tibia forward, they're saying, I don't feel what I felt on the other side. So I get the patient basically diagnosing it by the look on their face. They tell me. Another interesting thing that I've found on the uninjured side in Lockman, you won't feel the PCL as easily as you will feel on the injured side. So if you can translate a tibia in Lockman position further forward so that you get a better PCL endpoint on that side, that raises my concern. But I'd go every time for the Lockman, uninjured to injured, and the patient tells me by their quizzical look on their face, they know what's going on. When they don't feel that end point, they're using their proprioceptors to tell me.
And why do you think that a lot of the students are getting taught the anterior draw test? And you've said it before, Justin, and you both effectively said it there. You're using Lockmans, and we did get taught Lockmans at university as well. But why do you think they're still using anterior draw? Because I know you're not a fan.
It's in the textbooks, and they were written 30 years ago.
I guess I became a little bit more of a fan, in the days of double bundle, two bundle theory. You might, oops, I've got a phone call coming.
That's all right. We can still hear
you. Decline. Done it.
Yeah, that's it.
Okay.
Beauty of live podcasts.
That's right. So where were we with the anterior draw? Yeah, look, I still think there's a relevance. I think there's still a relevance to it, but I do find we were asked what was the most powerful reproducible. Certainly the Lockman. I think trying to persevere with a pivot in the rooms it can be difficult. I mean, it used to be something we had to try and demonstrate before MRIs existed. We had to be satisfied that we could perform that in the rooms, but less so these days. I'll go for Lockman and appropriate history and investigations. Yeah.
But getting back to your point, Tim, about functional instability,
yes,
I think a pivot shift test. So if a patient comes into my rooms and they're 2 weeks after an injury, and I can do a pivot shift test on them, there is no way they're going to heal or be stable enough to play soccer. But if
I understand.
If they come back then after rehab, they've been stiff and sore, and all I got initially was a Lockman, and then we rehab them, get them a full range of motion and a normal gait pattern, and come back and examine them. I will then push a pivot on either side, and if there's a difference, I say, do you feel that? And they say, oh, yeah, I don't like that. Well, then they're likely, when they run around vertically, to pivot. Whereas if they don't pivot and they don't really feel a difference side to side, I say, well, you might be a good one here. You might be able to cope. You might be a non-operative candidate.
Yeah, I think if we just move on to pivot, my understanding is that if you can pivot them in the room at whatever stage, they're more likely to be unstable in day-to-day activity, right?
Yeah.
So that's my sense of that. That if if they're an easy pivot in the room, they're even going to have ADL instability. Right?
Yeah.
You've mentioned it before, Justin, that the pivot shift's definitely the harder of the tests in terms of the Lockmans versus the pivot. And you said that a lot of your understudies over the years, you've had to show them over and over and over again how to do it. Have you got any tips for anyone out there trying to get the perfect pivot shift?
Yeah, I think it's a technique thing. It's not a force thing. So
yeah.
We've got a lot of female trainees now, a lot of female medical students, and a female with small hands can do just as good a pivot shift as some big bullfed with big hands, right? So it happens in that first 30 degrees of flexion. So you've got to have a patient with full extension. If they can't extend the knee, you won't get a pivot. So a patient's got to be relaxed with you holding their leg out straight, whether it be by the ankle, the foot, or even the calf, just, the lower leg, cuddling the lower leg out straight. Patient's got to be out straight. And if they won't go with you and they won't relax their hamstrings to come out straight, you'll never get a pivot, so don't force it. So it's full extension, allowing them to come out to full extension, internal rotation, and then just that first 15 to 30 degrees of flexion. Tim?
Yeah, I think part of the issue with the pivot originally was the original description was written backwards, I think, in the original article. So that turned everyone upside down. But yeah, getting them relaxed, allowing, basically you're wanting the femur to relatively drop back with the tibia to come relatively forward. And then really it's nothing vigorous. It's just flexing the knee and the tibia reducing back into the lateral compartment. Now, the other interesting thing is when you do it and you're successful in the clinic, they'll say, that's what it does. It is popping out. And then you have to describe to them, it is actually going out to in. But it's very interesting how the patient says, oh, that's what it does. It pops out like that. But it's actually coming out to in, which is just another interesting point to make. Yep.
Yeah.
In terms of artificial surfaces, let's dive into this. You both said that artificial surfaces do increase the likelihood of ACL.
No. That's one of my fences.
Were you on the fence?
Replay the tape.
All right. Why? The question is why? Why are you on the fence, Tim?
I think because the stats, and particularly if we look at Australian stats, that they're not great, to follow these injuries. We are seeing artificial surfaces sort of growing at the moment. So I think it's difficult with the stats. I know our human brain always wants to find one thing to explain the problem, right? That's how we work, and to start blaming a boot, a stud, a ground, I think it's difficult without evidence, and I suppose record keeping, better evidence in Australian conditions perhaps would be better to answer that question. So I think the papers available can go each way with cleats, with studs, with grounds, with we had a run of injuries in one of the league teams, and was it the sticky ground, or next week it might be the dry ground, and then it might be the artificial ground. I do know artificial grounds correlate highly with grazers, and they're terrible injuries.
Yeah. I agree. Multifactorial. Got to remember that the foot is the thing that plants on the turf. So you've got a boot of various type on the foot, and then you've got the turf, and then you've got weight of patient, you've got speed at which they're running, angles, velocities, a whole bunch of things. So I think what happened in Canada with the female soccer stuff was that they didn't change their boots, and so we learned from that. So then, Nike and Asics started making money because they had another boot they could advertise and sell, or a range of boots with the less grippy studs on there for the artificial turf. And but not every player has 4 sets of boots in their in their bag, and they don't go out and do Johnny Orchard's pedometer test before they line up on the track and the starter says go. So it's a multifactorial issue.
Yeah, you can't blame it.
In the end, the trigger is the sport. The trigger is the activity. And I don't think even the best cruciate ligament that we get, which is our first original one by whoever made us, was made to play touch footy, soccer, netball. It just was not designed for that. But we have an expectation that we can do that, and we can find ways to negate that injury, whether it's boots, grounds, training. But I think we'll be chasing that forever. And I think if ever we get the chance to meet who made us, they'll say, why the hell did you think that you could ever perfect the ACL? I didn't make it for that.
Yeah, good point. Very good point. And you're kind of damned if you do and damned if you don't in terms of artificial versus natural, because at least with artificial, people are playing all year round. The surface doesn't get slippery, it doesn't get muddy. Because I know that Gore Hill Oval, where North Shore Bombers play now in the AFL competition here in Sydney, that's artificial turf. But it's just such a good deck to train on, and it's a great deck to play on. But a lot of the boys down there are blaming a lot of the injuries that they're getting on the fact that now it's artificial. I think they've had 2 or 3 ACLs there this year. They've had a couple of syndesmosis injuries as well, where the foot's got planted and stuck. So have you got any blanket recommendations for people that are playing on more artificial turf than natural in terms of choice of boot, any other things that you would recommend they do to try and reduce their risk?
The advice I give.
Tim just said, "Don't play."
Don't play. Yeah.
No. But that's the trigger. In the end, that is the trigger. So a trigger for a second time injury. When we've done what we thought was a reconstruction that was perfect, the trigger's the sport. And the trigger is so. But look, I would like to make some sensible recommendations about that. But I don't think we really can, right? I don't think we can with confidence.
But I think, Tim, if you like take tennis, for example.
Interesting.
You would prefer them to play on clay and slide than you would for them to stick on the rebound ace. So if they're going to play, you want them to slide. And if they're playing on AstroTurf, or they're playing on really thick kikuyu that's dry, you want them to slide. So therefore, little sand shoes or dimples are better than the big blades. You would think, if the standard weight going through the foot, the blades will stick more, whereas the dimples will slide more. So then you got the.
I guess I got to be careful. I'd say I don't want to be taken as saying there's nothing in the boots and there's nothing in the grounds, right? And you probably make a good case for Dunlop volleys.
Yeah, I know.
I think because I've done a couple of little tests on myself. I've got multiple pairs of football boots, and I've got the bladed style versus more of your rounded stud, artificial versus natural. It feels completely different. When you change direction, when you've got the bladed boot on, you can definitely change direction harder, I think, and you can grip and you can push and you can create more force into the ground, I think, especially on the artificial turf as well. I feel like, but that's also a product of the surface doesn't move, and you also get that grip, so you don't get that sliding effect. So I think there is something in it, but at the same time, you can't do everything. But I think the number one thing with all these people listening that have done their ACL or they're concerned about potentially doing their ACL, you need to make sure that you're regularly training, you're doing things like the FIFA 11 plus, the netball first program, the football first programs. You need to be in the gym. You need to be doing plyometrics. You need to be doing all this stuff that I advocate, and Just Richardson and all these guys that are doing great things. So I think that is the number one thing that everyone should be doing, because we know with a lot of the research, the reducing risk of injury warm-ups like the FIFA and all of that, they reduce the injury risk by up to 50%. So it's kind of a no-brainer. You've got to do it regularly, go to training, do your warm-ups.
Absolutely, would support that, Andrew. I think that's a good point to be made. Yeah, excellent. Yeah.
Practice makes perfect. So there's no way, and that's why we're getting back to the time, Tim. The time. Can we jump to the time to return to play? I think if you've got a knee that's gone well and has been operated on, got a great position of graft, and we know the biology hasn't been inhibited by any recurrent effusions or any re-injuries, and everything's going well, and that player, as I get mine, to start practicing from month 6 or 7, if everything's going well, and they're practicing and they're increasing in complexity and gaining confidence and practicing. There is a risk that can be taken statistically if they return before 12 months. But still, the difference between them returning before 12 months and after 12 months biologically really can't be measured apart from practice, a video analysis, watching them cut and play and pivot. But I think it's practice. They've got to get into that practice. So yes, we keep them for 12 months, but if you've got a highly paid athlete who has practiced and they've got all their muscle memory back and their knee is quiet, the returning to sport, returning to play at 9 months, Tim, versus waiting for another 3 months and they miss $400,000 contract. What do you think?
No, I agree. And what I think there's also some untapped area of interest is that I am pretty sure a lot of our patients do a lot more than they say, even in the month 2 or month 4 or month 6. They might tell the therapist one thing or us another thing. So there may well be a tolerance to our grafts that we don't even understand, but you've had players and you sometimes see them, particularly when I was refereeing, I'd see some of the schoolboys they operated on running the water, doing the warm-ups with the kids when they're 6 weeks, 12 weeks down the track from their reconstructions, right?
Yeah.
And so you do wonder whether if we had some honest appraisal of what went on, when they're outside the physio room, outside our office, maybe we would learn a little bit more about the tolerance of the graft, the early graft and the loading of a graft early. It could be interesting. But we've all had people, I agree, back at, and there was a vogue at one stage, we had them back at 6 months, right? But we've shifted to 9. Now we're hearing 12. But I agree. Quiet knee, well muscled. They feel ready to go both subjectively and you've got objective parameters like your hop testing. I wouldn't be steadfast on must be 9, but closer to 9 these days than I was. Yeah.
If the patient was a little bit heavier, on the heavier side, would you want them to wait longer?
I haven't seen that correlation in a practical sense. But is there some research that I'm not aware of with regards to that? Yeah.
I don't think there is. I don't think there is, Andrew. That heavy patient, 7 out of 10 of them have ruptured their cruciate in a non-contact way. So I don't think that's ever been shown really. The contact injury potentially is an unlucky event, an accident, got nothing to do with neuromuscular, biomechanics, anything like that. So they, probably go back earlier, maybe. It's just like a patella dislocation, traumatic patella dislocation that goes out in them scoring a try, gets reduced, no damage. I let them go back pretty quickly. Whereas if they're a, hypermobile young girl who dislocates and then, it goes out again and, they're destined for, instability events, whereas a single traumatic ACL rupture, I'm pretty happy once I put a new graft in there and get them rehabbed, get them going if the knee's quiet.
In terms of testing protocols and rehab protocols, what are your thoughts? When I say testing protocols, I'm more thinking the Melbourne ACL Rehabilitation Guide and strength testing. What are your thoughts, Tim?
Yeah, I think at present, we don't have the objective clearance criteria. We like to measure things as humans and therapists and doctors. We like to have measurements, but to my understanding, we don't have the absolute clearance criteria. I think these assessments are good, and you could talk about the pitch ready as well. But in honesty, and they report it this way, that we are still just collecting data on this to be predictive of those who'll do well or those who'll re-rupture. I don't think, to my knowledge, we're there yet. So what do I look at? I guess simplicity, in that they are doing their hop testings to a symmetrical performance. They have symmetry of their quadriceps. They have full range without an effusion, a stable clinical examination. And they might be the objective criteria, but then I might ask the simple question, do you feel ready to play? Are you ready to go? And if there's a hesitancy there, I think you can often pick up on that hesitancy in the patient, they're not ready. If they're not ready to cross that line under their say-so, they're not ready. If the coach, the teammates, the parents are saying, you must go back, I'm saying that's not where you should be. You should be, in your own mind, ready to go. So some objective criteria, but I don't think they're predictive. And 9 months, quiet knee, symmetrical quad, stable knee, and a psychological readiness to go.
Justin?
Yeah, I agree wholeheartedly. The one thing I'm adding, Tim, is the RSI score.
Yeah, yes, ACL, RSI. Yeah, agreed. Because that's something I use.
Yeah, that helps. That helps. And what it does, what I like doing is I give it to them at the 6-7 month mark when I see them halfway through. And the young boys all score close to 100%. And they think they're really good. And then I turn around and say, mate, you failed. You scored. That's too high. You're overconfident. You got to go back and start again. And they look at me with a sad face, and then we get on with the plan for the next 6 months. But protocols, I'm a little bit jack of protocols. I think we've been through the protocol era, and I'm with Tim. They can guide us, but it's not, it's individual-based treatment. Objective and subjective treatment and evaluation, and returning to play. These tests, these batteries of tests that are out there, I think is things you've got to ask yourself, what are you measuring? You want to measure the risk of re-injury, and as Tim said, we don't have a measure to risk the re-injury. You want to measure whether they can pass a test. Well, that's easy. They can study and study and study and study to pass the test, and they'll pass the test. And that might be a measure of confidence in performance. So they're ready to perform and they're confident to perform, but it doesn't. And sometimes, and the review we did on the Swedish, the battery of tests that we measured, is that those who scored well actually had higher rate of contralateral ACL ruptures. So they were returning to us with another injury higher than those who scored less well. So it might have promoted a little bit of overconfidence. And so they got back and went a little bit hard in that first season back. So I'm just, protocols, I'm not a real big fan of. I've got them, they're all out there and they're good guides, but I rely on my physios and paramedical team and trainers and patients to tell me how they're feeling, or to look how the patient is feeling and performing. And that gets then to the point of, how much physio should they be having early, middle of the road, along the way, or at the end. I think at the end they need a little bit more focused treatment and evaluation and appraisal, rather than lying on a couch in the first 2 months, 6 days a week in their rehab. I think we've got to look at the back end for success.
I completely agree. I think physios are missing the mark with end stage rehab, and I think we can do a hell of a lot better job. We're not getting enough people back to their pre-injury status, and I think that's got a lot to do with the fact that the end stage rehab just is not good enough. I agree. I don't like rehabilitation protocols. I will say that I think protocols in terms of testing throughout an ACL rehabilitation is a good idea to a degree. And the reason why I think confidence is a big one. So I'll often test at 2, 3, 6, and 9 months. and I'll redo the 6 to 9 month tests if they do fail certain things. They also give the client a bit of an idea of where they're at. You know, what do I have to work on? What am I good at? What am I not good at? I also do the 9-month test under fatigue versus fresh. And I think that's really important because a lot of people miss that. They think that they're okay to, you know, go back to sport and go back to training when they're doing all of this testing when they're not fatigued, but often they're going to do their ACL when they're fatigued. So I think that's really important. But a lot of people need to understand that if you're passing these type of tests, it does not mean that you're going back to sport. It means you're returning to training. I think that's really, really important. It's a return to training, and then you need to get through a solid period of time where you're training before you're even allowed to go back on the pitch. Would you agree?
Andrew, I was just interested from your point of view, do you have patients where you might have pre-injury baseline data on them and then get them not to their pre-injury baseline position, but get them above that baseline position upon return? Because I guess most people we see, there's no way we've got any baseline pre-injury data on them. And so the concept of getting to their pre-injury state, or do we get them above that pre-injury state if we can understand what that might be?
Yeah, it's a great question. So all of my clients, especially my strength and conditioning clients, I'll typically test them at some point throughout their journey. And I'll often work with a client and we'll test them, say, every 6 to 8 weeks with strength testing to see whether the program for the corresponding sort of 6 to 8 weeks has worked. And we're heading in the right direction. So some clients, if they did do their ACL soon, I would have some of that data, which would be great to use. But yeah, in a perfect world, you would have all of this data with every one of your clients. You know, I've got Ellie Brush. I actually saw her a couple of hours ago. She's one of your clients, Tim. And she is just a freak when it comes to testing. She's an elite athlete. She's played at the elite level in soccer and Aussie rules for GWS and also, you know, the Wanderers and Sydney FC, etc. And she's a freak when it comes to testing. And she is the classic person that thinks like she's a hell of a lot more confident than most people. So she thinks she can do more than she's probably allowed at the moment. And there's a reason why now at 4 months down the track, she's getting a little bit of anterior knee pain because she just can't help herself. She's a classic example. But yeah, I completely agree. I think if we had pre-injury data, that would make the data that we're finding and getting in that 6 to 9 month period a lot more relevant.
Because the other concept too, when you're sitting out with an ACL for 6 months, 9 months, not only is your knee deconditioned, your whole body's generally deconditioned. And we might sit here, have a knee focus, but do we have a big me focus? Do we focus on that person who's generally deconditioned as well?
For sure. Yeah. I agree. Justin, you got something to say?
I think, well, for all the listeners out there, Dr. Tim Musgrove, when he was young, was actually a physiotherapist. So, Tim, how has your training, you know, in physiotherapy helped you, you know, influence your patients now returning to sport? Do you tend to direct them back to the physio at the 6 or 9 month mark if you think they need more physio, or do you sit down and write a program with them and get them to do it themselves based on your advice?
No, I suppose I don't. That could be a failing, actually. Justin, you make a good point. No, but I usually like to work with the physio and, you know, and prefer to pick up the phone and speak to the physio rather than write. So that would be more my style, to speak to the physio, point out the factors to the patient and then liaise with the physio more directly. Yeah.
Yeah.
So that
we don't have.
Although you know when it comes to the professional athlete, that might sound ideal, but does not happen always. You might say, don't think they're quite ready, and really, I mean, who are we to judge? We see them for, you know, a 5-10 minute consultation. I don't see them at training. I don't see them in the gym. I don't really see how they do perform. So I think that has to be an absolute shared decision at as much as it can at amateur level, and certainly at professional level has to be a shared decision.
Yeah.
How much time do we have, boys? It's 4 o'clock. Reckon we've got one more question, Eunice?
Well, I've got lockdown at 12 midnight, so keep me up, keep me out.
He wants to get outside, yeah.
Don't get me outside before
Yeah. One more. Sounds good.
One more question. All right.
Yeah.
The graft options.
Oh, here we go. Yeah.
Here we go.
What a good one to finish on.
Yeah.
All right. We'll start with this. Actually, speaking of Ellie Brush, she mentioned today that you pulled out, I'm talking to Tim here, you pulled out the Lars ligament out of your drawer to show her what it looks like after, I don't know, 15 years or whatever it's been in your drawer.
Correct.
Yeah. Let's just go into why you choose a certain graft based on the MRI, based on your clinical examination, based on the person, and also based on age, because I know, Justin, you do a lot of work with adolescents. Tim, we'll start with you.
Yeah, I guess I go with what would be a peer-accepted approach. And in general, if we look at registries, and I often point them towards the New Zealand registry, ACL registry, because we don't have one here, it's about 70% hamstrings, 30% patella tendon, with a little bit of a trend towards increasing use of patella tendon. I think there's something in that trend that some surgeons might be actually rediscovering patella tendon, so we might see an upswing in that. But I think if you play it safe and, hamstring or patella tendon is an appropriate graft. And I don't think now, with all the studies out there, that you can actually argue a big difference between them with outcomes. You might have certain trends, but to say there's significant differences, I think we're over that. So I would suggest, you do an operation that you do well, that you were trained to do, and use either a hamstring or patella tendon primarily in your first time injuries, with a leaning towards hamstrings. Then I might look at either sport or lifestyle specific factors, the anterior knee pain in a patella tendon. I'll explain to the carpenter, plumber, or others that might kneel, versus the hamstring. So there might be a little bit of discussion around that. I will involve them in that discussion. And I'd say it's interesting these days, the patient is often now the consumer. They're directing what's going on. They're almost buying an operation like a commodity. They're saying that I want an ACL reconstruction and I want it done with whatever. So I think there's greater patient input, which I think is all fine. And the way that I try and handle that situation in a practical sense is I'll point them towards either literature, but definitely the ACL registry from New Zealand. So I do thank our New Zealand colleagues for making that available to us. But primarily I'd go for an autograft, same side hamstring, and anecdotally and not scientifically, I tend to use patella tendon in the rugby league players. And I said that was anecdotal, non-scientific evidence.
Yeah, I agree with Tim. It's it's good to hear that we're thinking along the same lines, and I don't think there should be a big controversy like there has been in the past anymore. I think we've moved on from that. And I talk to patients about, again, the same with non-operative versus operative. What are we trying to achieve? We're trying to achieve a stable knee that allows a successful return to sport or functional activities for that individual in their own individual space. And looking at the literature can send you bonkers, really, because there's studies on everything. It's the most studied 3.5 centimeters of tissue in the world. So I have an a la carte approach now, and I say, this is, you've come here to the restaurant and I'm going to get to know what your tastes are and give you from the menu what I think is going to suit you and what you're going to enjoy and have a good experience with for the rest of your days. So that, and I'm a knee surgeon, so it's no longer one size fits all. I don't do hamstrings in everyone. I don't do patella tendons in everyone. There are some who need a lateral extra-articular tenodesis as well, and there are some who I think would an allograft, a cadaveric allograft, would suit very well. So I think along what Tim says, it's not patella tendon, hamstring tendon autografts are available. If you're a good knee surgeon, you should be able to make a decision on which one to put in and be able to do both. and recognise the advantages and disadvantages, the potential risks and complications of both. And if you have certain factors like the young patient, the hypermobile patient, the patient with a high tibial slope, the patient with a positive family history, you have to tell them and their parents that they're at a high risk of re-injury, up to 30%. So not to the one knee, but to both. So that individual 15-year-old boy who has a father and a mother sitting in that consultation room who have both done their cruciates once, if not twice or 3 times between the two of them, you've got to look them in the eye and say, yep, if you go back to sport after this reconstruction, you've got a 30% chance over the next 10 years of representing to me, re-injuring one or other of your knees. So I'm going to do this, this, and this. And they take a little bit more care and a little bit more discussion. And that a la carte approach, I think, is important. So it is a hot topic, probably one that we're never going to solve, but it's not just about the graft. And to come back and finish off with that, really, I think is probably a sensible way to do it. We've spoken about all the other things, and because the graft is not the only important factor here.
It's all about the individual.
Yeah.
I suppose that's the point Justin's making. I guess we make it individually specific when it comes to the graft, you could say. For sure.
Any last thoughts or anything to add, Justin or Tim?
Just on that, Lars. Every time I get,
can you just put the nail in the coffin here, Tim?
No.
Just put the nail in the coffin.
No, I will not. I will not do that because it obviously had a use in some people. I will not do that, right? That is interesting. If I've had a patient with a Lars ligament and I get it out of the drawer and show them, they say, "What is that?" And I say, "That is what is in your knee." And it's very interesting that it's often the first and only time they've ever seen it. So, anecdotally interesting that, they've never seen what was put in their knee.
Is anyone using the Lars anymore?
Not sure around town.
Not sure. You'd have to talk to
them. No, there was a place, I guess, I'm not, be very careful not to totally dismiss its use.
It's still on the market, but I don't know whether there's a rebate for an intra-articular use of it. I don't know.
Yeah. It was revisited, may have its place, but it's probably settled in a very small place.
Can we leave it with this question? What's the future of ACL reconstructive surgery?
Yeah.
Tim?
Yeah, I think we'll spend our time and spend our life. If you look at how many articles are written on this, and I don't think we'll get to perfection because nothing can better the first one that we got. So I think at some point we might need to say stop, that we've got a reasonable operation. And I think there's more to be done in the space of counselling, education, particularly about return to sport. The expectation that we can put something in there that will last. I think that's really important, particularly in the under 20s, particularly in those so-called elite juniors that feel they've got a career ahead of them. I think we just got to be a bit more responsible and aware in that space of saying, as Justin said, the re-injury risk is quite damning. And if we're putting them back in a situation where they're at high risk, we must have that conversation. We must arm them with that information so they can inform themselves about their return. So I think that's where we got to work more, not on the surgical side necessarily. I think on that side around return.
Yeah,
Justin?
Talking from the surgical side, I'm using the Olympics as an analogy at the moment. We're on the dais, but I don't think we're on the top step with the gold medal. I don't think we'll ever get there. We'll continue to be, we'll be on the dais, gold, silver, or bronze, but it's sort of, that's where we're going to go round and round. It's a good operation. We get people back to sport. Re-injury is always there. We aim for perfection. We aim for that gold medal performance each and every time. But I don't think we're ever going to say we can get there reproducibly every time. And it's all about the the whole individual rehab, the whole journey, and the recognition of you drive back out on that freeway, you're potentially going to have another accident.
I think that's a great place to leave it. Thank you so much, Justin, Tim. It's been a wealth of knowledge, and I feel like a lot of the listeners are going to gain a lot of insight because a lot of them are physio students and physio new grads, so they're going to appreciate all of the wise words you've given us.
Pleasure, Andrew.
We've had good teaching, let me say.
Yeah.
Was it bearable, Tim? I know it's your first podcast. Was it what you expected?
Can you just let me know whether we're recording or not, Andrew? This is unfair. No, it was good. Of course, it was good. Just I like just that informal discussion. It's much like the discussions you'll have with your patients in this more informal way. You know, I like to be quizzed about what we do. You know, and I think it's important that we answer those. And increasingly, the patients are asking. They're taking notes, and they're getting opinions that, like Justin said, it can do your head in sometimes when you're the fourth opinion and they're questioning the fixation devices. And I say, look, just pick one of those 4 surgeons you've seen, you'll get a good result. Okay. Yeah. So that's another thing I would say, that, you know, there are a lot of well-trained knee surgeons in our country, in our state. And so we're lucky that way too. We're well-trained.
Yeah. And Justin, you got any final words?
No, I just saying, well done, Tim, for a podcast virgin. You did very well.
That's right.
You nailed it. After some technical difficulties at the start, you nailed it.
That's right.
Yeah. Turn the phone off.
For the listeners, how can they get in touch with you if they ever do have any issues, or they just want to get in touch and pick your brain, or even potentially want to get in touch if they're a physio new grad or something like that and they want to jump in and check out one of your surgeries, something like that?
Yeah, I certainly would welcome it, but in the COVID times, unfortunately, we're more restricted. So
you're breaking up, Tim, are you?
Notre Dame, you have the other students. Am I there?
Yeah.
Okay, start again.
Start again. Go for it.
I was just going to say, in COVID times, it's difficult to have any extras in the hospital, in theatre, and even in consults. But if times do turn to normal, happy to have them along. And they're obviously more technologically smart than me. They can Google us, find our website. The website comes up, phone number comes up. Happy to chat at any time.
Justin?
Yeah, me too, Andrew. I just time on social media is too hard at the moment. I did start a way back, and so my best contact is through Google website, justinroe.com.au, and admin@justinroe.com.au, or justin@justinroe.com.au, and I'll answer emails till late at night. No problems.
If you're ever having any issues, just contact me and I'll get you in touch with the boys. This podcast is live on Google Podcasts, Apple Podcasts, and Spotify. Thanks again, Justin and Tim. It was an absolute blast, and we'll have to do a 2.0.
Andrew, thanks for the invitation.
Yeah,
My pleasure.
Andrew.
As usual, stay strong.